Good afternoon. We'll start.
Good afternoon, Father. Good afternoon, Doctor.
Okay.
Good afternoon, Doc.
Yes, good afternoon. We'll start now. It's 2 o'clock.
Yes.
Okay, I'd like to welcome everybody to this pep talk. Please mute yourself, but always show your video picture. Sign in your name, Facebook account, email address in the chat box. Please include names of companions attending with you. Use the chat box to ask questions and make comments while the pep talk is on. There'll be group pictures later on at the start and at the end of the pep talk. Please take the online learning cum evaluation test exercise or OLETE for mastery of learning and have a perfect score to get the certificate like the one shown below. Okay. I have placed the link in the Viber group as well as in the Facebook group. Okay. I hope Abet have placed the link also in the chat box. As a reminder, also 50 OLETE certificates. If you get 50 OLETE certificates and pass 50 OLETEs, then you are entitled to 1 voucher for a ROJoson telemedical consultations. So let's now have a group picture taking before we start in 2 minutes. Please show your face. Okay. 1, everybody's in. Okay. 1, 2, wait. 1, 2, 3. I have a patient empowerment program in which I like to empower the lay people or patients to take control in the management of their health. There are 3 courses in the pep talk. I completed the core course on October 9, 2021. And from October 23, 2021 onwards, I have been tackling health disorder and health issue courses. This may take 3 years or longer. My pep talk today is entitled Fundamentals and Generalities in the Medical Management of Right Upper Quadrant, RUQ, Abdominal Pain, and Gallbladder Disorders. This is part of the Health Disorder course. For the empowerment objective, this is for the lay people to have an understanding of the fundamentals and generalities in the medical management of right upper quadrant, abdominal pain, and gallbladder disorders. Last March 19, I tackled the abdominal disorders, an overview, in which I identified I selected 5 common abdominal disorders, which are abdominal pain, abdominal mass, obstruction, bleeding, and jaundice. We have tackled practically all. Now, I will now, on the abdominal pain, I zero in on the right upper, right lower, and today we will be talking about the right upper. But before I discuss the right upper, right lower, and right upper, I had an overview of abdominal pain also on March 26. Okay. On April 2, I discussed the right lower quadrant abdominal pain and have a focal discussion on appendicitis, which is a very common cause for a right lower quadrant abdominal pain. For today, we will be tackling right upper quadrant pain here in the right upper quadrant. And a common disorder here is the gallbladder disorder. So these are the topics that I will be covering today, right? What is right upper quadrant abdominal pain, different types, causes, how common, clinical diagnosis, paraclinical diagnostic procedure, basic treatment modalities, and then I will have a overview of gallbladder disorders and the management. So definition of terms in the title and delimitation of coverage of my talk. I use the word fundamentals to mean the simplest and essential facts and theories which can serve as a basis or foundation and support for advanced information. And generalities as to mean the general statements or information, not covering specifics and not too detailed. Medical management, diagnosis, and treatment usually done by the physicians. So what is a right upper quadrant abdominal pain? Right upper RUQ stands for right upper quadrant. And RUQ abdominal pain means pain or unpleasant sensation in the right upper quadrant of the abdominal pain. So right upper quadrant is the location of the pain in the abdomen. So what is the implication of this right upper quadrant abdominal pain? So all tissues and organs in the right upper quadrant area of the abdomen could be the source of the right upper quadrant abdominal pain. And the right upper quadrant, the source of the right upper quadrant pain can come from the abdominal wall, peritoneal lining, internal organs in that particular area. What are the different types of right upper quadrant abdominal pain? Essentially, the different types of right upper quadrant abdominal pain will be based on the origin of the pain in that area. So, as we know, the belly consists of the abdominal wall, the lining, which we call peritoneum, and then the solid organs, and the hollow organs inside the abdominal cavity. So this could be the source of the pain, and then we will then use them to mean the different types of abdominal right upper quadrant abdominal pain. The cues for the which particular tissue or parts of the abdomen involved will be dependent on the type of pain. Okay, if the abdominal pain is constant and superficial, then we suspect abdominal wall. The pain is coming from the abdominal wall. Then if the pain is constant and deeper, when we press deeper, we should be thinking of peritoneal lining as the source of the pain. And then for solid organs, again, the pain is constant and deeper or the deepest. For the hollow organs in the abdomen, if there is pain, now it's usually crampy or colicky. So this is how we distinguish the source of the pain and the type of the pain based on the characteristic of the pain. What are the causes of the right upper quadrant abdominal pain? All tissues and organs in the right upper quadrant could be the source. As I said, abdominal wall, lining, internal organs, both solid and hollow organs. So for the solid organs, you have the liver, pancreas, then the gallbladder is a hollow organ, right colon, hollow organ, small intestines, hollow organs, and then right kidney, solid organs. So it's a combination of solid and hollow organs in that particular area, right upper quadrant. And all kinds of medical conditions and diseases in these tissues and organs can cause abdominal pain. But generally, it's inflammation, tumors, and stones. These are the common causes of right upper quadrant abdominal pain. How common are the right upper quadrant abdominal pain? Quite common, but we don't have concrete data comparing the frequency of pains in other organs, in other quadrants. Okay, it's not rare, it's common. Okay, clinical diagnosis of right upper quadrant abdominal pain. The processes that we use in the clinical diagnosis of right upper quadrant abdominal pain includes the pattern recognition and the prevalence process. Okay. So pattern recognition processes means realization that the patient's presentation conforms to a previously learned picture or pattern of a disease. Whereas the prevalence process means the choice of diagnosis is based on the frequency of occurrence of a disease in a certain locality, in a certain age and sex group, and in the affected organs and systems. So the priority is pattern recognition and then prevalent process. So the tips in the clinical diagnosis of right upper quadrant abdominal pain, we usually use the basic evaluation methods, which include history taking and physical examination. In the history taking, we try to get symptoms, so what the patient feel, and then in physical examinations, we try to get signs. Once we get all the data of the signs and symptoms, we now process them in to come out with a clinical diagnosis. So some tips, more tips here will be try to determine the type of pain as best as you can in this area. So you ask the patient, what type of pain do you feel? And then feel for any associated symptoms like fever, nausea, vomiting, diarrhea, etc. And then try to recall any antecedent or precipitating event that may lead to the pain. Then after that, monitor closely the pain, the course, and its associated symptoms, because this will be helpful in giving us some more clues as to the diagnosis. So try to determine the type of pain as best as you can. As I said, the simplest way to do this will be if the pain is crampy or colicky, then you think of the hollow organ involvement, like the intestine, like the gallbladder. Okay. If it's not crampy, it's not colicky, okay, it can be from any source. It can be hollow organ or solid organs. Strictly speaking, it should be colicky for hollow organs, but in the early stage of the disease, of the medical condition, the pain of the hollow organ involvement can also be not crampy at the very start. Okay. Then feel for any associated symptoms, okay, like fever. If fever is present, you think of an inflammation going on. If vomiting, you think of possible obstruction. Diarrhea, possible enteritis or infection of the intestines. Then urinary disturbance, possible kidney problem. Recall any antecedent events. Okay. Example, history of recent vehicular accident. So you think of possible blunt injury to the right upper quadrant, or history of exposure to people with jaundice, so possible hepatitis. So you try to get some clue from some precipitating or antecedent events. Okay. Monitor closely the pain. Okay. So after the onset, you have to monitor closely the course of the pain, as this may give clue to the diagnosis. Example will be, over time, the type of pain may be clearer. So umpisa, medyo malabo, no? Okay. In character to enable pattern recognition of a medical condition. Example, initially, pain from a hollow organ is just dull pain, but as time goes on, it becomes colicky, then you think of a hollow organ involvement. And again, over time, the appearance of associated symptoms may enable a pattern recognition of a medical condition to be diagnosed. Okay. So example, fever, there could be some inflammation there of the gallbladder. Okay. Now, for the physical examination, we look for some signs, and then we also palpate. Okay, so this is what is called sign-based evaluation based on physical examination. So some tips here in the physical examination. So we look for any unusual bulbs, which may suggest a mass, buccal. Then you look for distension of the abdomen. Kung lumalaki ang tiyan, then you might think of intestinal obstruction or even a mass. Then after looking, you palpate. Possible presence of a mass. Minsan, the mass is too small that it cannot be seen from the externally. Then you have to palpate. Then you also palpate for the presence of tenderness, pain on pressure. If present, then you have to evaluate further. Okay. In looking for the specific cause of the right upper quadrant pain, abdominal pain, we use pattern recognition of a particular medical condition or disease and prevalence process in those with similar presentation of signs and symptoms. And then after that, we try to come out with the primary. Primary means most probable clinical diagnosis. Secondary, the second most probable clinical diagnosis. So general statements on the clinical diagnosis can run like this. Right upper, okay, it should be upper quadrant abdominal pain secondary to non-specific cause or specific cause. Or it can also be the other way around. Specific cause as the primary and non-specific cause as the secondary diagnosis. If there are cues for a specific disorder, such as a mass or obstruction, then we specify the disorder and then look for the specific cause. If there are cues for a specific disorder and a specific disease, then we look for the, we specified, example, if there is a mass here, we think that there is a mass in the right upper quadrant, so that's a disorder. Then we look for the possible cause. Is it coming from the liver, coming from the gallbladder, coming from the intestines? Those are the examples of specific causes. The early stage of the medical condition or disease or a mild medical condition and the sources of pain usually produces no symptoms, produces no distinct character or nature, just mild symptoms, okay, if it's in the early stage, okay. That's why it's really hard to determine what is the specific cause. So in patients with right upper quadrant abdominal pain but without clear-cut cues, walang bukol, walang obstruction, and abdominal pain is just mild with no clear-cut characteristics or no clues whatsoever for a specific disease, then we can put the diagnosis as non-specific right upper quadrant abdominal pain. But this has to be monitored afterwards, and then if need be, it can be changed to a more specific diagnosis. At times, watchful waiting may allow more distinct character. Monitor lang, and then so the character of the pain will come out, and then it will help us recognize a specific disease. The onset and course of the abdominal pain can be an aid to the clinical diagnosis. When acute means recent or about a week or two. Chronic means lasting for about 3 months. Recurrent means three episodes within 3 months. These are the definitions that we use in medicine. Progressive means increasing intensity, in severity. So some abdominal conditions and diseases have typical course. Some have chronic and recurrent track records, such as chronic cholecystitis, on and off. Okay, chronic, lasting for about 3 months, on and off. Others just occur once, okay, and rarely recurs. And then progressive, when you have progressive course of the pain, then it connotes a serious diagnosis. Okay, more attention should be paid to the patient, and there must be a quick action in the diagnosis and treatment. Again, some abdominal conditions and diseases have typical severity score. Some are usually mild, some usually moderate, some usually severe. So example of pain caused by gallbladder stones causing acute obstruction, these patients will have very severe abdominal pain. Okay. So we classify severity of pain into mild, moderate, severe. Okay. So severe pain, aside from implying the greatest urgency, pag masakit na masakit, it has a greatest urgency, dapat magamot na kagad. So, but it also have a connotation in the diagnosis and subsequent treatment. Example is when you have a severe pain, we're thinking of the so-called acute abdomen, acute, masakit na masakit. Huh? Okay. So in medicine, we have these terms. Okay. Acute abdomen is a condition usually with very, very severe abdominal pain that demands urgent, quick attention and treatment. And then acute surgical abdomen, we just add the word surgical, just to mean a condition that needs urgent attention and operative treatment. Kailangan operahan, kahit na papano, okay? Acute non-surgical abdomen is one that does not need operative treatment, but it needs urgent attention. So sometimes the specific cause of the acute abdomen cannot be definitely established. Mahirap sabihin kung which one is the real cause. But it is enough for the physician to decide whether it's a surgical or non-surgical abdomen. Okay. So this is a special category of the clinical diagnosis of the abdominal pain, in which you don't have to be very, very specific as to the diagnosis. Paraclinical diagnostic procedures for right upper quadrant abdominal pain. Common instrumental and laboratory diagnostic procedures for right upper quadrant abdominal pain include imaging procedures, X-rays, either plain or with contrast, ultrasound, CT scan, MRI, PET scan, endoscopy, usually upper, but sometimes you have to do lower endoscopy when the large intestines are involved, and the large intestine is located, the right large intestine is located in the right upper quadrant. And then some blood tests that may also be done, CBC, liver function tests, tumor markers, etc. The foremost indication for a paraclinical diagnostic procedure can be stated this way. If you are not certain of the primary clinical diagnosis and you need to be more certain before a treatment, then you have to go for a paraclinical diagnostic procedure. And to decide on the indication of the paraclinical diagnostic procedure, the physician uses two processes. One, determine first the degree of certainty on the primary clinical diagnosis, and then compare the treatment plan for the primary and secondary clinical diagnosis. So as a rule, there's no need for paraclinical diagnostic procedure if one, you are quite certain of your primary clinical diagnosis, example, 90%, 95%, 99%, okay? And the treatment plans for the primary and secondary diagnosis are the same. Okay? So you don't need to do paraclinical diagnostic procedure anymore here. The competencies required of physicians managing right upper quadrant pain is that they should know all the uses and indications of all known laboratory and instrumental diagnostic procedures for the right upper quadrant abdominal pain. Okay. They must know how to use them, and then as needed and as indicated, and then they should help the patient select the most cost-effective ones using the so-called BRCA process, and then they should also know how to interpret the results. The BRCA process is shown here. B stands for benefit, R, risk, C, cost, availability. In the first column, the physician lists down all the options and then give data on BRCA and compare. And then from the table of data, you will recommend a particular procedure which is the most cost-effective. Acute abdomen is a condition usually very severe, okay, that demands urgent attention and treatment. So in patients, because of the urgency, in patients with acute abdomen, some at times there's no time that should be wasted on the paraclinical diagnostic procedure just to establish the definite cause. Okay. So a surgeon should operate without establishing the specific cause. This is justified. The operation, when he operates, the operation can serve both as a paraclinical diagnostic procedure because is going to see what's inside, as it will establish the cause. Okay. Basic treatment modalities of right upper quadrant abdominal pain. So here, the basic treatment will be three: surgical, non-surgical, potentially surgical. Surgical means the condition, medical diseases needs an outright surgical treatment based on track records, and then non-surgical at all times, no operation at all, and then potentially surgical, it can initially non-surgical, then eventually surgical when needed. Okay. So in this table should be listed down the medical conditions or medical diseases, and then try to classify them into whether it's surgical, potentially surgical, or non-surgical. Examples of outright surgical abdomen, meaning patients with right upper quadrant abdominal pain who has diseases that needs operations as a main treatment modality, will be examples will be acute surgical abdomen. Because of the word surgical, it needs to be treated right away with surgery. Complete intestinal obstruction, complete na barado, okay, because the intestine might rupture anytime. Peritonitis, secondary to ruptured liver abscess, so infection of the lining of the abdominal cavity. Resectable tumors like cancers or non-cancers, which is causing problem. So the surgery should be done as soon as possible, okay, or is the treatment of choice. Examples of surgical treatment for right upper quadrant abdominal conditions will be drainage infection. Example, if you have liver abscess, then you drain and then you remove. Ectomy. If you have a tumor there, you can do a colectomy. If you have a liver tumor, you can do hepatectomy. Okay. Then if you have a infection of the gallbladder, you can do cholecystectomy. Ectomy means removal. Then you can also, another type of surgical treatment in that area will be repair. If you have, let's say, an injury to the large bowel or small bowel there, then you can have a repair. Or injury to the liver, bleeding, then you repair the wound in the liver. Examples of potentially surgical, meaning pwedeng gamutin mo na, no surgery needed, but which might eventually need or which may lead to a surgical abdomen. Examples will be asymptomatic gallstones. Pag hindi pa masakit, we can observe. No? Then if the gallbladder stones become symptomatic, then operation is done. Again, for polyps, asymptomatic gallbladder polyps, usually asymptomatic, but when it starts to grow bigger and bigger, then operation will have to be done. Incomplete intestinal obstruction, then if it becomes complete or tend to progress to complete, then operation should be done already. Okay. Another example of potentially surgical abdomen is asymptomatic benign tumors, which may at times in the future becomes bigger, grow bigger, and then cause problem, so that there's a need to do the operation. Examples of outright non-surgical abdomen will be hepatitis, viral, so you don't operate on viral hepatitis. Cirrhosis, meaning destruction of the liver, we don't operate on that. And then urinary tract infection, no operation is needed. Okay. So examples of non-surgical treatment will be use of medicines or no medicines at all, just watchful waiting, because expecting all the symptoms will disappear spontaneously, or natural support management, like change of lifestyle. Okay. So BRCA process in selecting the most cost-effective treatment modalities, just like in selection of the paraclinical diagnostic procedure, BRCA can also be used here. You list down the various treatment procedures or options, and then benefit in terms of goal of treatment, risk, cost, availability. I'll now go to the last topic, which is management of gallbladder disorders. This is one of the common disorders in that area, in the right upper quadrant. So gallbladder disorders are common that all lay people should be aware of them, recognize them, know what to do, and be knowledgeable of how physicians usually manage them. So this is part of our patient empowerment program. So this shows the gallbladders located underneath the liver. Then these are the ducts, common bile duct. It channels the bile into the common bile duct and into the intestine. The gallbladder is a part of the digestive system of the body. The main function is to store the bile coming from the liver. The bile helps break down fats. The bile is a mixture of mainly of cholesterol. These are the substances: cholesterol, bilirubin, and bile salts. Okay. So the question is, can one live without a gallbladder? The answer is yes. You just have to, the body has just to adjust because of the need for the digestion of the fats. Okay. But the bile, even without the gallbladder, there will be bile going down from the liver directly, then to the small intestine. The disorders of the gallbladder the common disorders will be acute cholecystitis, which means inflammation of the gallbladder, and this is commonly associated with stones, okay, very common. And then gallbladder polyps is another gallbladder disorder, and then gallbladder cancer, which is rare, but carries a very, very poor prognosis. In all patients with right upper quadrant abdominal pain, cholecystitis with gallstone is always a possibility and should be considered in the evaluation. with gallstones being the most common cause of the cholecystitis, because cholecystitis and with gallstones is the most common cause in this particular right upper quadrant pain. But although it's common, we have to remember it's not absolutely true, because not all right upper quadrant abdominal pain are due to cholecystitis and gallbladder stones. So other diagnoses should be considered at the back of our mind, such as diseases of the liver, pancreas, other organs in the area, and also the so-called non-specific medical conditions. So among the gallbladder disorders, the reason why gallbladder stone with inflammation is considered because, number one, based on statistics, it's a very common condition there, causing right upper quadrant pain. Number two, why don't we think of gallbladder polyps if you have right upper quadrant pain? Because gallbladder polyps are usually asymptomatic, walang nararamdaman. Okay. Gallbladder cancers usually asymptomatic at the start, and it develops symptoms only when it's big and advanced, and it's not so common, it's rare. Gallstone with cholecystitis are usually painful. Okay, as I said, if there's pain, you suspect gallstones with cholecystitis. But sometimes gallstone without cholecystitis can have no pain. So remember all these conditions that might help you in the diagnosis of right upper quadrant pain. Think first of cholecystitis with gallstone as most or the number one possible cause, but remember that other causes are still possible. So right upper quadrant pain in this area, okay. The liver, the gallbladder, okay. Stomach is here, duodenum, okay. And then here, gallstones, gallbladder, gallstones. If the stones got impacted in the cystic duct, this is labasan ng bile, labasan ng bile and stones, okay, from the gallbladder to the system, to the common bile duct. If it got impacted, nakabara, lalaki ito. Okay, this will enlarge and then there will be pain. Masakit na masakit, no? Okay. So if the stone got into, lumusot siya, punta rito, kakaroon ka ng jaundice. Diba? So this is an example of normal gallbladder, okay? And then here you have stones causing cholecystitis. No? There is swollen mucosa and inflammation of the gallbladder. So this is a very common condition, cholecystitis secondary to gallstones. So the cues for the diagnosis for acute cholecystitis, as I said, when you diagnose acute cholecystitis, usually it's caused by gallstones. Okay. The cues for this diagnosis is that there is definite, persistent, and progressive pain and tenderness in the right upper quadrant, in the area of the gallbladder. Okay, in the area of the gallbladder. In medical parlance, we call it the Murphy's sign. Okay, Murphy's is just the name of a physician who popularized this sign. So when I'll go to the next slide. Okay, the patient's Murphy's sign is elicited when the patient stops breathing in and then winces with a catch in breath because masakit na yung gallbladder. Okay, pag dinidiin, masakit, hihinto yung paghinga niya. Okay, so this is what is called the Murphy's sign. So to elicit this, we ask the patient to exhale and then take a deep breath. Okay. Then, if there is pain in that area and the patient stop the inhalation, that is what is called the Murphy's sign. So a Murphy's sign is very useful in the diagnosis of cholecystitis. Okay, as I said, cholecystitis can be usually caused by gallstones. So suspect gallbladder disorder after you suspect acute cholecystitis. Okay, do not suspect gallbladder stones disorder first. Okay, before if you don't have cholecystitis. Okay, The foremost cue for the clinical diagnosis of a gallbladder disorder is the presence and symptoms of acute polycystitis. Ito yung mauuna, no? Okay. And as I said, reliable cues will be presence of definite, persistent, progressive tenderness in right upper quadrant pain at the area of the gallbladder. Okay. So gallstones as a cause of acute polycystitis is primarily suspected only because it is very common. Okay. As I said, may mga yung prevalence process natin pumapasok din, di ba? And gallbladder polyps and cancer are not usually suspected because they are usually asymptomatic, wala namang pain, and they're only diagnosed on ultrasound and other imaging procedures. Para clinical diagnostic procedures for gallbladder disorders, the options are ultrasound, CT scan, MRI, and others, but the most cost-effective so far is still the ultrasound. So this is the first choice when you have to do a paraclinical diagnostic procedure for patients suspected to have gallbladder disorder, then we do an ultrasound. CT scan and MRI are done only if there are questions, if there's a need for further information after the ultrasound. So as a rule, MRI is better than CT scan in terms of information yield. No? Okay. If we were to compare CT scan and MRI. So this is an example of an ultrasound of a normal gallbladder. Okay. This is the shape, a pear-shaped gallbladder. And then this is the stones. Okay. So ultrasound uses echoes. No? Mapasok ang echoes dyan. Kaya nakikita mo yung mga echoes here. This is what we call the so-called posterior shadowing. No? Mga echoes. Okay. Polyps are those mga tissues attached to the wall. Nakakabit sa wall of the gallbladder. Unlike stones, it's floating. Okay, like this one, naka-floating stones. Polyps naka-attach sa wall of the gallbladder. So here, this is the gallbladder. Then this shows the thickening. If you have inflammation of the gallbladder, you can have thickening or edema of the wall of the gallbladder. Okay, so this shows that there's a stone on the neck, okay, causing inflammation of the gallbladder. Okay, and then with the inflammations, at times you can have fluid forming around the gallbladder. So that is what is called pericholecystic fluid. Okay. Again, gallbladder polyp here inside. Pag maliit like to, we usually, it's hard to recognize the gallbladder polyp from gallbladder cancer, but we use the size as a gauge. No? If it's small, usually we call it gallbladder polyp. But if it grew into a big size, we now suspect gallbladder cancer. No? So gallbladder cancer are usually attached to the wall also, the wall of the gallbladder. Okay. In contrast to the stones are floating. In contrast to polyps, the polyps are very, very small, okay, less than 1 centimeter usually, okay. So, management of gallbladder polyps, okay. So you can see the samples of polyps here, nakalawit sa pader, sa wall of the gallbladder. Gallbladder polyps are usually incidental lang, napasama lang sa findings of ultrasound and other imaging procedures. They're usually asymptomatic. Walang nararamdaman ng pasyente. 95 to 99% are not cancer. Okay. If the polyp is less than 1 centimeter, multiple, marami, pedunculated means ito, may stalk, okay, pedunculated. Okay. This one is sessile, walang stalk. Okay, this is more dangerous. Okay. So if the polyp is less than 1 centimeter, multiple, marami, saka pedunculated, no surgery for cholecystectomy is needed. Just surveillance, just observe. But if the polyps are suspicious for cancer, ganito na, polypoid, sessile, and the size, it's progressively becoming bigger, then surgery is indicated. This is an example of a cholesterol deposits. Okay. Dilaw ang kulay. Okay. So these are pseudopolyps, not real polyps, deposits. So for gallbladder cancer, if the polyps are suspicious for gallbladder cancer, example, it's sessile, and the size is getting bigger, more than 1 centimeter, okay, then surgery cholecystectomy is indicated. If gallbladder cancer is detected and still operable, again, surgery is indicated to remove the entire gallbladder with the cancer. But at times when it's diagnosed, it's already late, then it's not resectable anymore. So we have to content ourselves with doing palliative and hospice care. Example of stones in the gallbladder. Okay, it can be 1, it can be 2, it can be many, it can be of various sizes. Gallstones may be symptomatic or asymptomatic. There are patients in which you have gallstones seen on ultrasound but wala siyang symptoms. These are called asymptomatic gallstones. The symptomatic gallstones are incidental findings on ultrasound and other imaging procedures. The gallstones are not causing abdominal pain or distress, whereas symptomatic gallstones are those that are causing abdominal pain and other side effects like jaundice. For asymptomatic gallstones, regardless of the number and size, watch and wait can be done. No surgery is immediately needed. After the first onset of symptoms, kung sumakit na, okay? So basta right upper quadrant abdominal pain, then, and it's for sure it's due to the gallstone, the pain's due to gallstone, then surgery is needed. Okay. When you do surgery, cholecystectomy for gallbladder stones, you remove the entire gallbladder with the contained stone, not just the stone. Okay. Because if you just remove the stone, it will recur. As I said earlier, removal of the gallbladder with the contained stone is recommended. Okay. And then there are no more cost-effective treatment procedures aside from surgery, because a lot of times people would use apple flushing and other homemade management, no? But this has been shown to be not cost-effective. So if you have gallstones which is symptomatic, go for surgery already. In the surgery for the gallbladder stones, the whole gallbladder is removed, no? Not just the stones, as there will be significant risk of recurrence if you just remove the stones. And besides, losing a gallbladder is not a risk factor because, as I said, you can live without a gallbladder. So you might as well remove it, no? Para wala nang recurrence, wala nang recurring problems. In cholecystectomy or surgery for gallbladder removal, there are currently 2 general procedures: conventional open and minimally invasive cholecystectomy. Under conventional, there's another category here, is open mini-lap. Okay. Unconventional, it's long incision. Open mini-lap is also open, but this incision is smaller. Here, these are examples. Okay. Laparoscopic cholecystectomy is small holes, okay. Long instrument inserted. One is a camera, okay, that is attached to a TV, to a monitor, and then these are grasping and cutting instrument to remove the gallbladder. Okay. In open, there is a big incision here, conventional one, okay, and then they remove the gallbladder through that incision. In mini-lap chole, a small incision about 2 inches or less than 2 inches, then you remove the gallbladder. In open traditional, the usually it's more than 2 inches. Okay. So options, if you compare the different options, lap chole, number 1, option 2, mini lap chole, option 3, long lap chole. Okay. So the benefit of the lap chole is small incisions, less pain, early return to work, okay, compared to the other 2. Now, but the benefit of the mini lap and open or long lap chole would be shorter operating time. So these are the advantages. Now for the risk, higher risk for lap chole because of higher complication rate, particularly bile duct injury. Now for the cost, most expensive for the lap chole because of the special instrument that will be used. Now availability, some centers not readily available. Okay, but for the open cole, whether mini lap or long lap, they can be done anytime. So this is how we use the BRCA to compare the three options in terms of lap cole, mini lap, and long lap cole. So I think that's the last slide for the talk. A summary takeaway, I have expound on the right upper quadrant abdominal pain. What is it? Different types, causes, common, how common, clinical diagnosis, paraclinical diagnostic procedure, treatment modalities, and a focus on gallbladder disorders. Takeaway in relation to patient management, be always in touch with reliable medical information and fundamentals and generalities in medical management of right upper quadrant abdominal pain and gallbladder disorders. Knowledge is power, it gives power. Use the 4 Ks of patient empowerment like kaalaman, kakayanan, karapatan, and kapangyarihan to gain greater control over decisions in the medical management of right upper quadrant abdominal pain and gallbladder disorders. I hope I have empowered you to have a better understanding on the fundamentals and generalities in the medical management of right upper quadrant abdominal pain and gallbladder disorders. So before we go to the open forum, reminder, Olete, pass the test, get a certificate, 50 Olete certificates, 1 voucher for ROJoson telemedical consultations. Okay, let's now have a picture taking. Everybody on board? Last call, ladies, daily. 1, 2, 3. Wala na pahabol. Okay. The floor is now open for questions, comments, reactions, consults, etc., etc. Anybody who wants to throw the first questions, reactions?
Thank you, Doc. Thank you so much. This is my first time to attend this session.
Welcome, Mercy.
Hi, Doc. Pasyente nyo kami ng nanay ko.
Yeah, I know. Okay. Welcome.
Yes. Thank you, thank you. Salamat, Doc, kasi ang dami naming learnings. Sobra.
Hindi mabigat. Hindi mabigat.
Sorry?
Hindi mabigat ang aking lecture.
Perfect po, Doc.
Okay.
Meron kasi akong gallbladder polyps.
Okay.
2020, I had my ultrasound. So it was diagnosed, nakita doon na mayroon ako. Pero 0.1 lang po, Doc. 0.1 cm.
Okay.
So, for monitoring lang naman daw po yun.
Good. So,
ayan po. And yesterday, nag-follow up ako, Doc, ng ultrasound. The same size pa rin naman po.
okay. Just one. Only one? One polyp lang?
Ang nakalagay doon, tiny polyps po ang nakalagay sa
May S. May S.
Yes
Polyps.
po, may S.
Okay. Okay. So just observe lang. Tama. Okay. Pag,
Yes.
okay. Okay. Pag yung mga semen, pag may polyps, yan ang problema, no? Okay. Pero hindi ka naman OFW, wala. Okay.
Hindi po.
Okay. So, kawawa yung mga semen, no? Usually they have some routine examination, nagpapa-ultrasound. Once they saw polyps, pinapatanggal ng strict speaking, pwedeng hindi. Pero a lot of yung mga medical examination companies are asking the patients to have them removed, no? Okay. So, Kawawa naman siya.
Pero Dok, kung gugustuhin ko, okay lang na ipatanggal ko.
Bakit mo ba patanggal? Bakit mo gugustuhin?
Hindi po. Napapraning lang ako eh.
Kaya nga that's why we have this pep talk. Di ba? To allay your fear. Okay? To allay your fear. No? Okay? So once you have something in your body, you diagnose it first. Okay? That's a general guide that I can tell everybody. Diagnose it, and then if it's not something that will cause serious problem, no, okay, 99%, 90%, it will not cause serious problem. You just observe. You just observe. Don't go into the treatment, no, okay. Hindi man kailangan, no, okay. Baka sabihin ko, okay, baka sabihin mo, ay, ayoko, baka I want to avoid yung baka magka-problema in the future, no? So, ganun ang usual thinking, no? I suggest don't think that way, no? So, lahat ng bagay in the future, we cannot predict, okay? So, if you're thinking of the gallbladder problem, yun pala, may ibang problema nag-set in, like breast cancer, like thyroid, no? Okay? Just observe lang. Just observe lang.
Yes po, yes po.
Okay?
Thank you po. Thank you.
Don't have it removed. Just have it monitored every now and then. Ultrasound lang.
Yes po.
Okay. Any more comments, questions? Thank you for sharing, Mercy.
Thank you din po.
Is it true that when you have your gallstone removed, you'll become bigger?
Bigger?
Yeah.
Hindi.
Okay.
Hindi. Okay. Pag nag-become bigger, masyado kong maraming kinakain mo na. Okay.
Sabi kasi nila wala na daw pantunaw.
May bile pa naman dumadaan, di ba? As I said, yung gallbladder is just a storage for the bile. And the bile is just used for digestion of fats, di ba? Okay. So once you have your gallbladder removed, there's still bile coming down from the liver to help in the digestion. No? So baka sabihin mo, baka indigestion of fats, baka pwede pa. Pero usually, i-adjust mo lang naman eh. Kung may nararamdaman ka compared to before when you have still the gallbladder, bawasan mo muna yung fat mo. No? Okay? Until mag-adjust yung katawan. No? Okay. Okay. Any more? Who has gallbladder operation now? Sino na-operahan na?
I think baby.
Ako po, Doc, si Christine.
Oh,
Nagkaroon na ng lap cholecystectomy
okay.
many years ago. Bale, actually, parehas kami ng sister ko. Parehas kami nagkaroon ng lap chole. Pero yung symptoms namin magkaiba. Sa kanya, wala siyang naramdaman. Ako may naramdaman.
Symptomatic, asymptomatic kayo.
Yes. Parehas po yung sinabi nyo kanina, Doc. So ngayon naintindihan ko na bakit yung sa kanya hindi niya naramdaman. Yung sa akin, naramdaman ko yung pain. May naramdaman akong pain.
Okay.
Ngayon gets ko na siya, Doc. So thank you Doctor for explaining po talaga. Kasi ngayon naintindihan ko na talaga siya maigi.
Okay. So yung sa iyo, symptomatic.
Symptomatic po. Talagang sobrang sumasakit siya. Hindi po talaga siya yung tolerable, as in talagang sobrang sakit niya na, so talagang dinala na ako sa doktor for surgery na agad.
Yeah.
Kasi sobrang sakit niya na po talaga.
Sa right upper quadrant.
Opo.
Okay.
Lap chole po, bale pinadaan po sa pusod.
Yeah, okay. So, yung bakit nagpa-opera yung kapatid mo?
Yung sa sister ko naman po, hindi ko alam kung paano nangyari sa kanya, pero malalaki po yung sa kanya, green piece yung laki. Yung sa akin po, sobrang liliit naman po. Sobrang parang pamintang laki po.
I have a slide there kanina regardless of the size, di ba? Okay.
Mm-hmm.
So, don't use the size. Ang daming tao na gano'n. Ay, maliit yan, delikado yan, baka lumusot, operahan. Kung yung naman, masyadong malaki, sabi nila, ay, pwedeng hindi, baka hindi naman nakakalusot yun.
Noong nung nalaman ko po na pares kami ng situation, sabi ko, bakit ganun, te? Yung sa'yo malalaki, yung sa akin ang liliit, tapos sa akin sumasakit, sa'yo hindi. Kaya ngayon na-gets ko na po yung sa explanation niyo, yung kung bakit gano'n, kung bakit nga wala pala sa size yun.
Yeah.
Kumbaga talagang sa pagdadaanan mo talaga sa akin kasi talaga sumakit po talaga, hindi ko na talaga siya nato-tolerate.
Unpredictable talaga. Okay.
Yes po.
Okay. Just pag wala kang nararamdaman, ano na lang, observe na lang. Okay.
Mm.
Okay. Huwag mo nang unahin yung ano. Kasi as I said in life, there are other problems that might crop up. Kung yung niwo-worry mo, hindi pala yun ang dapat i-worry mo, di ba?
Kasi nag-ano po bago ko inoperahan, in-exam din ako, binigyan ako ng parang yung ultrasound, kung ano yung kung meron ba talaga siya, kung saan man nanggagaling yung sakit. Kaya po na-distinguish talagang maliliit yung sa akin po.
Nakita sa ultrasound, maliliit.
Opo.
Okay.
Maliliit po talaga siya. As in, sobrang liliit po. Sabi po nung nakakita.
Yeah. Okay. So once you have a pain, make sure, kasi not all pains have, as I said, yung gallbladder can be asymptomatic, di ba? Okay.
Mhm.
Walang nararamdaman. Once you have pain in that area, right upper or epigastric sa gitna, no? Okay. Wag mong i-assume kagad na it's due to the gallbladder stones, no? Okay. You still have to look for other possible causes like gastritis, no? Peptic ulcer, no? Ganon, no? Kasi a lot of be wary of a lot of surgeons, physicians, kasi very dekahon na yung the ultrasound, di ba? Ang daming unlike before, walang masyadong ultrasound. Ngayon, lahat may ultrasound of the abdomen. So pati yung mga asymptomatic lumalabas, di ba? Asymptomatic gallstones lumalabas, no? Okay. So make sure when you have pain, no, mahirap nga, pero okay. The best guide will be look for some clues that might point to the gallbladder being the cause. Number one, kung may inflammation doon sa gallbladder, thickened ng gallbladder wall, no, that could be a sign that the pain is coming from the gallbladder stones. Okay. Number two, more on the right upper quadrant in gallbladder. Okay. Pag nasa gitna, medyo may duda. Kung nasa gitna ang pain, no? May konting duda, no? So kuminsan, you may have to go for endoscopy to check kung baka yung pain mo galing sa gastritis, no? Okay. Kasi pag inoperahan ka ng gallbladder stones, no, akala ng doktor, akala mo galing doon, yun pala after the operation, andyan pa rin ang pain mo. Diba? Because it's due to gastritis or other causes. Okay.
Pero after naman po nawala na. Talagang naging okay naman po ako na after. No?
Yeah, that's good. Good for you. No? Okay, but what I'm saying, there are in other patients, ganun nangyayari. No?
Oo nga po. Totoo po yun.
Tanggal ng gallbladder, basta may yung iba naman, yung ibang doktor kasi, basta may gallbladder stones, tanggal na. Okay? Wala nang room.
Ano po nun, Dok, tsagang naiyak na ako kasi sa sobrang sakit niya, naiyak na po talaga ako. Hindi ko na po talaga tolerable. Nagpapadala na po ako sa ospital. Yeah.
That's why I said, okay. So pag baka nagbara dun sa neck of the gallbladder, kaya masakit. No?
Opo.
Okay. So any question?
Thank you po, Doc.
You're welcome. May question si Belet?
Doc, my mother underwent gallstone surgery many years ago, but for almost a year now, she is experiencing on and off abdominal pain. What can you say about this?
Years ago. So we go back. Natanggal ba yung gallbladder?
Yes, Doc.
Natanggal yung buong gallbladder niya?
Opo.
Okay. So assuming natanggal yung buong gallbladder niya, tapos, okay, we go back to the basic, yung unang module natin, abdominal pain, di ba? Saan ang abdominal pain niya?
Parang palipat-lipat po.
Palipat-lipat. Okay. So walang fixed na area. Okay.
Wala po.
So hindi natin mapipinpoint. Can be non-specific, di ba? Okay? So palipat-lipat. Any associated symptoms?
Parang medyo masusuka daw po ang pakiramdam niya.
Palagi?
Pero
Palagi pag may nararamdaman siya?
opo, tapos po parang pinagpapawisan daw siya.
Kailan pa
Malamig.
ito? Kailan pa ito?
Tagal na po, doktor, mga isang taon na daw po. On
Okay.
and off.
On and off.
Hindi naman po araw-araw.
Walang, okay.
Kakain kakaiba daw ganon. Tapos yung pagdubi niya parang hihirapan din siya. Minsan daw medyo malambot, minsan matigas yung gusto niya.
Ayan ang sinasabi ko, you have to inquire on the associated symptoms. Kung nahirapan dumumi, that could be another clue, di ba? Okay. And then yung papasuka, another clue, di ba? So i-weigh lang, no? Wala kang nakakapangbukol, diyan.
Wala naman po. Sabi ko kung may nakakapa po, wala naman daw pong nakakapa. Parang may hangin lang po. Hangin.
May hangin. Ilang taon na yung mother mo?
85 po.
85. Okay, 85 with such a condition. Walang masakit dun sa gallbladder operation niya, dun sa area na yun.
Parang wala naman po.
O di siya naninilaw?
Hindi po.
Okay. So with such a data that you're giving me, number one, it's either, sabi ko either it's non-specific or specific, di ba? Pero since wala kang makitang isang condition that will tell you that this is it, now you label it muna as non-specific, non-specific, no? Kasi kung may nakita tayong bukol, yun, specific na yun ang cause, di ba? Okay? Bukol could be, kung may bukol siya, nakapangkapana, baka bukol nagkakos ng obstruction, na kaya sumasakit, di ba? Okay. So, and then, kung non-specific, as the primary diagnosis, secondary is baka may specific cause like a tumor because of our age, di ba? Okay. So, one, you can observe, no? Kung during the observation, kung lumalabas na yung may pattern na yung palaging masakit, no? Hindi siya nawawala, no? Okay? Kung on and off lang, okay lang 'yon, no? Okay. Kung yung sakit ay persistent, na tuloy-tuloy at naging progressive, then you suspect it's more than a non-specific one, then you may have to do some tests already, no? Some tests like ultrasound, like CT scan, gano'n, no? Okay.
So ang gagawin na lang muna po yung ganon. O, matagal na pong ganon lagi nang nasakitan siya niya. Pero hindi naman po araw-araw. Pag nakakain po siya ng kakaiba, nasa din siya niya.
Yan nga, non-specific lang yan. I suppose all of us have experienced that. Di ba? Kahit nasa age natin ngayon. Okay? Pero after a while, nawawala. Ngayon, after a while, babalik. Di ba?
So pero best na muna yung magpa-ultrasound. Ultrasound ho ang pinaka-best muna.
Kasi kung non-specific siya, hindi mo ma-pinpoint. So, kung hindi mo ma-pinpoint, as I said, either you observe or kung hindi ka kampante sa observation, baka sabi mo, baka mahuli ka, baka meron talaga. No? So, you have to do a test. No? So, among the tests, kung sa abdomen, kasi buong tiyan yun, di ba? Buong tiyan. Okay? Yung i-examine mo yung buong tiyan, di ba? Para malaman mo kung ano yung problema. No? Okay? So, options number 1, ultrasound, CT scan, MRI, tatlo. No? Okay? So, how do you choose? Yung pinakamahina dyan, pero pinakamura is ultrasound. Okay. Ang pinakamagaling dyan, baka MRI, no? Pero pinakamahal, di ba? CT scan, in between, pwede, di ba? Pero meron din kamahalan, may 20,000, di ba? Ganon, 18,000 plus yung may radiation, no? Okay. So, if you're concerned about the cost, no, you can go by ultrasound muna, parang screening. Okay? Yung ultrasound makakatulong kung sakaling yung tiyan, yung sakit niya nasa upper, na baka yung ultrasound is very useful in evaluating the liver, the gallbladder, no? Wala na siyang gallbladder na, di ba? So mahina yung ultrasound sa stomach, sa intestine, mahina, no? Okay. But ultrasound can also be good for the kidney, evaluate the kidney, no? Okay. So, kung gusto mo i-observe mo kung talaga kung saan sumasakit, kung saan ang pinakamadalas makit, kung may isang area, let's say right upper quadrant, kung ang liver, gano'n, di paano mo na, ultrasound mo na lang. Otherwise, pa-CT scan na lang para makita lahat.
Okay po.
Para minsanan na lang. Buo.
Salamat po, Doc. Thank you very much po.
But take note of the cost. Siyempre, mahal din yun. Di ba?
Okay po.
Okay.
Salamat po, Doc.
Any more questions? Wala na sa chat box, Tabet?
And at the chat box.
Okay. Last call for any question. Okay. Kung wala na, before we leave, okay. The next topic will be pancreatic tumor. Pancreatic tumor. Then after that, baka hemorrhoids after. No? Okay. Okay lang sa inyo? Pancreatic tumor and then hemorrhoids. No? Okay. So we're now on our first anniversary actually. We started the PEP Talk May 15, May 14 na ngayon, di ba? So naka 1 year na tayo, no? Okay. Okay. So, but yung series is 47 pa lang, di ba? So I still have 3 more before I reach the 50th PEP Talk, di ba? Okay.
Hey, Doctor. Meron pala akong last question. Which do you recommend, lap chole or surgery?
Kung ang gastos ay kaya naman because covered by PhilHealth, lap chole na lang. No. Okay. Kung hindi, then open chole na lang.
Are they the same? Kasi yung isa, you will remove it. The other one is that you will burst it. Will it not recur?
Hindi, pareho tinatanggal. Pareho
Okay.
tinatanggal.
So hindi lang siya yung pinasasabog.
Hindi
Okay.
burst yun. Tinatanggal yung buong gallbladder by the long instruments. Mahabang instrumento yun eh.
Okay.
Habang tumitingin sa TV monitor, tinatanggal. And then, after that, ilalabas dun sa sa isang maliit na butas. No? So, the whole gallbladder tinatanggal. Hindi lang bursting yan. No?
Okay.
Okay. So,
Now I
kung gastos ay kaya yung budget, then lap chole na lang. No? But make sure you have a good surgeon. Kasi ang pinaka critical factor doon, yung pagka na-aksidente, no? Okay. Kasi mas malaki ang risk sa sa lap chole, no? Especially those who don't know how to do it expertly, no? Okay. Okay? So if there's no more additional question, let's call it a day. We'll see each other next week. Pancreatic tumor. No? Okay.
Okay.
Bye-bye.
Bye.
Thank you so much, Doc. God bless po.
Thank you. Thank you.
You're welcome.
Thank you, Doc. Bye.
Thank you
Okay.
po. Bye-bye.
Ano po kayo?
Welcome.
Thank you, Doc.
Thank you po.
Oh. Bye-bye.